Hello, everyone. This is Steve Kelder and bringing to you this webinar on learning to live with coronaviruses. We're going to start in just a few minutes while others log in and get to this site. Just want to do a few house cleaning details. This webinar is brought to you by the Michael and Susan Dell Center for Healthy Living at the UT School of Public Health and the Austin campus. And the center's vision is healthy children and a healthy world. And our guests today, if you've been tuning into our webinars, are familiar to all of you. Dr. Joe McCormick and Dr. Susan Fisher-Hoch. So just let's wait maybe another minute or so as other people climb on board. Another bit of housekeeping, it was already said that this will be recorded and will be posted on the website of the Michael and Susan Dell Center. And if you have any questions during the talk, just put them in the chat box and I will be monitoring them, and I'll try to turn them into categories that near the end of the webinar, I will ask our speakers what they think about these topics. And so anyway, maybe we'll just go ahead and get started, just to be timely. So let me just give a brief bio on these two. There are at the School of Public Health, they are our virologists. They have been in the trenches and have learned a lot about diseases and spent a fair bit of their career trying to understand them. Dr. McCormick has his MD from Duke and MS from Harvard. He worked at CDC. He's worked on the Lassa fever project in Sierra Leone and Ebola epidemic way back when it first emerged, and has just done a lot of instrumental and amazing work in virology and its prevention, its understanding physically, but also in its prevention side. He's the current or the former dean that started the campus down in Brownsville and is now responsible for bringing in lots of health resources and information to the entire lower Rio Grande Valley, Texas, and through these papers recently to the world. Dr. Fisher-Hoch, she's a physician with a doctorate in epidemiology from London University and the Royal College of Pathology and Virology. So she is our card-carrying virologist who spends time in the lab thinking about how many people have COVID, how many people have different diseases, what causes them, and then again, how can we work to keep people safe, both on the treatment side and also on the prevention side. So without further ado, I will open it up for Joe and Sue, and welcome again to our table here at the center, and appreciate you being willing to give us an update that includes the Omicron virus. But we all need to learn to live with this, don't we?
Well, we're wondering.
Yes, we have put a question mark at the end of this because we didn't want to say to people, you must learn to live with coronaviruses. But we are highly concerned that we're going to have to, regardless of whether we want to or not. So today we're going to try to update you on all of the current outbreak with the Omicron variant, and we're going to talk a lot about the variants and their difference. We're going to talk about the vaccines and their current effectiveness with the variant. We're going to talk about testing. We're going to talk about, and then we're going to talk about treatment. There are a lot of new breakthroughs with treatment. So we have a lot to cover. So we'll get started. I think
we're also going to try and explain why the virus behaves in a certain way and what our own behavior does in terms of the spread of the virus, because these are very important issues in terms of epidemics.
Okay, well, let's get cracking.
So here is currently the current map of what we call the hot spots of COVID and Omicron in particular, which seems to have overtaken most of the other variants, the Alpha and Delta variant, and we'll talk a little bit about those differences. But you can see the hot spots now. The hottest spot here appears to be. Did we lose our?
Can you hear us?
Can you hear us okay?
Yes, I can.
Oh, okay, sorry. I thought because our screen changed.
Yeah.
Sorry. These
I
are
just
hot
logged off
spots.
my camera, so it changed a little bit, but you're fine.
Okay. You can see the dark areas are the hot spots where there is a tremendous amount of disease being reported. But I think and the lighter spots are where less number of cases. You can see the scale up here in terms of colors, and with the darker ones being the higher level. However, and this is what WHO currently is telling us about the number of cases worldwide, 340 million so far, with 5.5 million deaths. So this is definitely a major pandemic. And one of the things that we have to say, though, right up front here is that local, national, and global data are subject to major reporting artifacts. Even within the United States, there are major issues about reporting. For example, right now we're seeing a lot of in-home testing. None of that is getting reported, or very little of it's getting reported. Poor communities in places like South America and Africa and parts of Asia are not being tested at all, essentially, because they don't have the capacity either to test or to report. People don't come forward for testing. We know that people are dying at home with this disease because they don't have access to care in many parts of the world, and they certainly never get tested or reported. Even in the United States, we have seen that phenomenon, particularly during the high peak times. Home testing and other kits that I mentioned. Testing will miss a lot of the asymptomatic infections because they don't think they have the infection, so they don't get tested. And as I mentioned, it will also, there are also people dying at home, particularly in some remote areas, without ever being tested.
So I'm going to take over with the variants. And I thought it was about time, if you didn't learn it at school, which I did. The Greek alphabet, alpha, beta, gamma, zeta, epsilon, zeta, eta. I have to chant it. But it's sort of come to the forefront because we decided to use it for these viruses and to get away from the rather clumsy numbers and letters that virologists use to denote where the changes are. So where are we? We have two kinds of variants that WHO recognizes: variants of concern, which are called VOC for short, and variants of interest, VOI. Variants of concern are the ones that have really worked through communities. And so here you have Alpha was the first variant. The original strain did not have a name, the one that came from Wuhan. Alpha was the first variant in the UK. Then there was a sort of subvariant called Beta and another subvariant called Gamma. Then we got a new lineage called Delta. All these, down to Kappa, were part of the Delta lineage. And then we got a Lambda and Mu, which were different as well. And these were, in fact, more significant. But it isn't until we get right down to Omicron, we get a new lineage. So that's where the naming comes from. If it confuses you, pull out the Greek alphabet and run down it, and you'll see how far we've got. And you'll see that we are more than halfway down the alphabet. And this is a little bit worrying. So the variants of concern, Delta and Omicron, are distributed like this. Again, as Joe pointed out, there is a reporting artifact. You'll find out whether it's Delta or Omicron if you have the tools both to collect the specimens and to identify the variant. So we tend to see them more frequently in countries where we've got much higher grade of laboratories. Interestingly, the Omicron started in South Africa here, where in fact there is not much reporting, but the Johannesburg has a very, very good virology laboratory, and they were right on top of it. And that's how they were able to detect it quite so early. And that's why we think it started in South Africa, but we're not that sure because it could have started in any of these countries which don't have a laboratory that's capable of identifying them, and it then spread to South Africa. So how does it compare to the other variants of concern? And there's a very important differences. This was the peak last year. You can all remember January last year. And we had the average peak, the 248,000 cases average a day. But here you will see the deaths and the hospitalization keep pace with the actual epidemic. During the Delta wave in the fall, late August and September, the deaths lagged a little bit, but they did reach a similar peak. So they went more or less pari passu. But this time, you see the enormous increase in cases and deaths, and the hospitalizations have increased. It's still bad enough, but it didn't go up the same way as the cases. And once again, it's reporting artifact will play here. Where have we got tests? We've got a lot more rapid antigen tests, a much bigger distribution of tests. Therefore, we're testing more people. So you will tend to see larger numbers, which sort of brings us to the fact that our previous president was probably correct, that testing made it look worse. Testing does make it look worse because you actually see the cases. But what it does is hide the problem if you don't do it. So across the world, testing and surveillance shows that the Omicron is increased everywhere, every single country. And the most important thing here to notice is the shape of this slope, how rapidly it went up, much, much faster than the previous slope of this is the Delta wave. See how much more slower this is and how really acute this is. There is some indication that some of these places, certainly South Africa, maybe even the UK and now probably the US, are beginning to drop off a little bit. But it's early days to be too confident about that. So the actual reported cases, as we've seen before, are actually more than double those that we saw during Delta. And here, the same kind of reporting processes were in place. So this difference probably is real. We really do have an enormous amount of this virus around. So the number of cases means that there are hundreds, billions, millions, billions, and trillions of viruses around in the community. So Omicron certainly is increased testing, cases reported, and hospitalizations. But here you will see here are the cases. Here hospitalizations, they are going up. So it does continue to be a problem. Please don't think this is just another dose of the flu. This is still killing people, still filling hospitals.
These are different. The scales are different.
Yeah, the test by day and the new reported test by day. So, but what we do not know is that the age you are matters a lot in terms of hospital admissions. So the older people here are much more likely to be admitted to hospital, but all ages are being admitted to hospital. We are seeing hospitalizations, intubations, and deaths in 20-year-olds as an everyday event. So once again, do not think just because you're young, you're going to get away with it. Unfortunately, it has ways of getting around even your best aspirations. I'm going to pass over to Joe now to talk about a little bit about the testing.
So I want to talk about testing and give you an idea of what we're facing with and what different tests do for us. So this is just a graph that shows you at this point here the exposure to the virus, exposure to another person. If you went to the grocery store or something and didn't wear your mask. Okay. And what happens is the virus starts to replicate. And it goes up, as you see in this cartoon here, up to a certain peak. And at some point, usually within a couple of days now with Omicron, you start to be infectious. What does that mean? It means you've developed enough virus in your upper respiratory tract that you can spread it to other people. And so there is a period of time when you are infectious. Now, shortly after you are infectious in terms of how much virus, you then start to develop symptoms if you're going to. Not everybody develops symptoms, and especially now with Omicron, not everyone who is fully vaccinated, for example, will develop symptoms even though they may get infected. And some people who are not vaccinated will develop minor or almost no symptoms as well, although you're much more likely to develop symptoms if you're unvaccinated. Anyway, at some point, you stop being infectious. That is, your immune system is kicked in. It will kick in earlier if you're vaccinated, and you stop becoming infectious. That is, you can no longer transmit it and you will eventually clear the virus. So this is a decrease in virus, doesn't mean it's all gone away. And then let's look then at differences so the average incubation period for early on was what you see here, was a longer incubation period. Delta came along, which was more severe, and you had a shorter incubation period. Omicron is much more infectious. Now, the difference is Delta was not as infectious. There wasn't as much virus in the upper respiratory, but it was much more likely to get to the lower respiratory and cause severe illness. Omicron replicates tremendously, lots of virus. You get shedding earlier, and you're more infectious earlier. Now let's look at what happens usually with a positive test occurs when you become, after you've incubated for a couple of days. And the differences are pretty significant between, say, Omicron and the earlier ones. Over here on the right-hand side, you can see we're looking at exposure, and then a graphic here again of the of becoming infectious. And what we see with a PCR is that early on, earlier than we see with the antigen tests, is we see PCR start to be positive. And then we see a period of time here when we have a lot of virus on board, as indicated by the peak here in this brown area, where you're infectious, and also you have a lot of virus around. And that means that you are much more likely to see the positivity with these non-PCR tests, particularly the lateral flow tests and some of the antigen tests. Because you have a lot of virus here, you're much more likely to be positive, but you also won't the positivity for that test won't last as long. Now, one of the reputations that the antigen test had early on was not very sensitive, didn't pick up enough infections. Now, because we have a lot more virus in the upper respiratory tract, it's become more sensitive, but the PCR is still sensitive for longer. Why? Because with PCR, we're actually making copies of the RNA of the virus, whereas the antigen tests are simply looking at the various proteins of the virus. We can't replicate those, but we can replicate the RNA, and that's what the PCR does. That's why it's more sensitive for a longer period of time. So that explains a little bit the differences in the, oops, sorry about that, I forgot to turn off my phone. That's why we see the difference in the two tests, and they have their advantages. If you can test at home, that's obviously some advantage. On the other hand, if the test is not very sensitive, you may not be positive. You may develop positivity next day or the day after, whereas if you did a PCR, you might find that it's positive. So those are the trade-offs. What you do after that is also very complicated. We're not going to try to get into that, but there may be some questions about it. One of the issues here with the variants of concern has to do obviously with transmissibility, and that's what we see that's tremendously increased with Omicron, but less severity. That's what we saw, very severe disease with Delta, with Omicron less so. Risk of reinfection much higher with Omicron, and perhaps even eventually escape from vaccine. And also the Omicron has made the antigen test more sensitive because there's more virus there to find. And that's the difference between that and the Delta as well, and some of the earlier ones. I'll turn that back over to
now
Sue.
I'm going to go and give you a little bit of molecular virology, because this is where virology gets to be a lot of fun, because we know a lot about viruses and we know a lot about how they work, and understanding how they work is really not just interesting, but it gives us a lot of information about how we can fight them. So here are variants of concern. We've gone through them. You see these are the number of mutations they have. And the striking thing about Omicron, which really scared us, was the number of 36 different mutations. This means it's changed its RNA, and it actually changes the protein that the RNA makes either on the surface of the virus or inside the virus. So each one of those is capable of changing the properties of a virus, its transmissibility, its severity, or its ability to evade the immune response. So this is a scary number of mutations. And in fact, this virus has turned out to be really quite impressive. So we need to take a much closer look at the spike. So every spike on the coronavirus, because that's what your immune system sees, is made up of 3 identical proteins. It's called a trimer. They're twisted together, making a little, it looks like a little bit like a head of broccoli. I'll show you a picture in a minute. And each stalk, each of the 3 stalks has 3 vital regions. And these are called the receptor binding domain. I'll explain that in a minute. The N-terminal domain and the furin cleavage site. So let's take a close look at it, see what it looks like. As you see, it's twisted, it's like a head of broccoli. Here are the 3 pieces. Here is the terminal domain. This is what your antibody sees. And this is the furin cleavage site. And that has important functions in terms of getting into the cell. So the delta lineage, which we experienced in late summer and fall, had these mutations, 1, 2, 3, which were quite important in terms of severity. Certainly this disease was more severe. They did induce some kind of mutation, a little bit of escape. But when we got to Omicron, you can see the picture is quite different. This is spattered with yellow spots. And these little yellow spots all represent a mutation, which means the shape of the actual spike at that point has changed. So your antibodies may not be able to see them so well. So let's look at the 3 components of the disease that really matter to us. Transmissibility, how easy does it transmit? Well, this transmissibility is in the receptor binding site, which is in this area, this bit just at the base of the cauliflower head. And if you look down here, you will see here, this is the same area with the mutations laid out. And you will see the receptor binding domain, there's only 1 in alpha, 3 in beta, 3 in gamma, and 2 different ones in delta. Only these 2 are the same as alpha, but then there's all these other changes in this area in Omicron, which allows the virus to get into your cell more easily. So that's one of the changes we found. The next change is in immunity. Can you actually, your antibodies that you've got from the virus or from previous infection, can they see this new virus? And so here is the N-terminal domain, which is the bit that your antibodies see and they attach to and stop the virus from getting into the cell. And here are the Omicron mutations in this area, like the top of the head of the broccoli. And here is a little breakdown of the various VOCs, variants of concern. Alpha and Omicron have the same ones here, but Omicron has already got some different ones. It so happens that this particular mutation, interestingly, from the point of view of testing, is one of the targets of one of the PCR tests made by Thermo Fisher, and we happen to be running that one. And what happens is, because of this mutation, the Thermo Fisher does not see the spike. And because the Thermo Fisher does not see the spike, there is an absolutely distinct pattern on our readout from the PCR. We can say, oh, that's Omicron right away. So this morning we ran our test, we ran 53, 57% were positive. And of those positives, every single one had this dropout. So we were able to tell our city this morning at about 9:30, yes, all your tests yesterday were Omicron. So that is now a useful piece of information for public health. Now, severe illness is the one where we understand it far less. And this is the furin cleavage site. Furin is an enzyme that is in every single cell in your body, and it's to do with transmission of virus from cell to cell. And therefore, it's very important in the lung because that's how it spreads within the lung. And here we have 3 changes in that area with Omicron. Whether they actually are able to make it less pathogenic or not is totally unclear. There is some mouse data that suggests that it fails to turn on a certain protein within the alveolar cells that allow transmissibility. But all of this is unclear, and we're going to have to wait for more science, probably a lot more animal studies in order to really understand what's going on. So having sort of looked at all that, you say, well, these variants come up, what's going on? And what viral factors allow the virus to produce these variants? So very high rates of infection, which we have with Omicron, means billions and trillions of new replication events every moment, in fact, right across the world. So you've got to think of the actual virions, which is a single virus, in terms of gazillions. I don't think even trillions does it.
Right.
So there are so many. So each one of these viruses is trying to replicate. Each time it replicates, it may make multiple errors. So it doesn't always get its copies right, particularly with RNA viruses, which are not the same genetic material as we have. We have DNA. It makes more mistakes, and there is no error correction. In our own cells, DNA, when it repeats itself, has an error, a mechanism for correcting errors. It doesn't always do it, but it usually does. But these viruses don't have any kind of, it's like a Microsoft spell check. It doesn't come up. Anyway, most of these mutations, these mistakes it make no difference at all. And some of them are actually fatal to the virus because it means it doesn't work properly, so it can't go on. But multiply that by billions and trillions and maybe gazillions, and variants with new or different properties may emerge, a very few of which may give the virus an advantage. And these are the ones that then overtake all other viruses. And this, if you don't believe in evolution, come into a microbiology lab and we'll show it to you in fast forward. It can happen as you actually watch it. And this is what viruses do. So what about the human factors? I'm going to pass over to Joe now because this is a different.
So here you've just heard about the fact that the more replications you have, the higher the chance of getting a variant, and particularly a variant that may have some impact on the population level. So high rates of infection in unvaccinated people obviously means much more replication of virus and potential for emerging of a new variant. Vaccine refusal is essentially the same thing. You get a lot of people who are unvaccinated, and so the virus can replicate at much higher levels. High rates of infection in crowded, disadvantaged places, and the pictures you see here are some of the festivals that have been held particularly in India, where you have literally hundreds of thousands of people at a festival. This is like a cauldron of transmission for almost any virus.
The virus.
Yeah, it's a feast for the virus. Failure to wear masks, obviously for this virus, because it's transmitted in the air, it's an airborne virus, so that also plays a role. And also we have a lot more people today in the world who are immunosuppressed, people who are on treatment for HIV. And HIV itself, it's not the treatment of HIV, but the HIV itself that immunosuppresses. But we also have people being treated for cancer, for autoimmune diseases and others who are on, and people with transplants who are on immunosuppressants. Those, and data have been published showing those people can have very long persistence of coronavirus and can replicate the virus for weeks. And so that's another potential source for variants to emerge.
And another point about those people is if it persists for weeks, it's persisting in the face of immune pressure from the individual who's trying to get rid of it and failing to get rid of it, which means as it mutates, it will select mutations that evade that immune pressure.
Exactly. Those will be the ones, either the ones that are mutations that are fatal to the virus will not emerge, or ones that are that can be stopped by the antibodies of someone will not emerge, but the ones that can evade that are the ones that may emerge. So there are a lot of vaccines out there. We know that the ones that are prominent for us are the Pfizer vaccine, the Moderna vaccine, and the Johnson & Johnson. They have different properties. We've already mentioned the fact that Moderna, probably because of the way it's given, the interval is given, as well as the fact that it's a higher dose of mRNA, gives you a little bit more of a response than the Pfizer. They'll both work very well. Johnson & Johnson is a different type of vaccine, and it gives you a response that is not as good as the mRNA. The same is true for AstraZeneca. It's a very similar one to Johnson & Johnson. There is a new vaccine, Novavax, that is being tested, and they have now requested approval. It's a completely novel vaccine that's a nanoparticle vaccine using proteins from the virus, and we'll have to see what the data look like. It's not yet available commercially at all, but it is being reviewed right now by the FDA. So just to reiterate what Dr. Fisher-Hoch talked about, this is what we are DNA people. We have DNA as our primary gene, type of gene, and there are viruses that also have DNA. Herpes viruses, cytomegalovirus, smallpox, adenovirus, and chickenpox are all DNA viruses. That means that they have to make copies, RNA copies, to copy themselves. Then we have negative strand RNA viruses that also have to make copies of themselves in order to replicate. And then we get down to the positive strand ones, which includes SARS-CoV-2 virus. And there, all bets are off because the RNA can make protein directly, as you see from this cartoon. And of course, this RNA is also highly susceptible to mutations. And that really is what makes this virus so dangerous, because it can mutate and mutate and mutate. And it doesn't care how many of those are fatal for itself. It just keeps on mutating until it can replicate, and it will try to evade anything, whether it's an antiviral drug or an antibody. It will make viruses that may escape, but either one or both of those.
So let's talk about mRNA, because I think a lot of people thought, oh, when this vaccine came out, it's too new, nobody's worked on it. So I thought that we just have to take a moment to look at the history of who has been working on mRNA, where these vaccines actually came from. They are the result of at least 20 years, if not 30 years, of intense study. So they are not new at all. They just happened to find an adaptation which was really useful. So I'll just tell you the story of the Moderna vaccine development, because the data on the Pfizer vaccine are not as clear, and we haven't had the story out like we have about the Moderna vaccine. There was a woman called Catalina Caricco. She is from Hungary, and you can see by looking at her, she looks kind of Hungarian. Anyway, she was a scientist in Hungary and was not getting along as fast as she wanted, and ended up at Penn State in the 1990s. At Penn State, she had startup funds. Some of us know what those are, where they give you some money to get going and then expect you to get your own funding. And she was working on mRNA. And she said, I can do anything with mRNA, which is a nice thought. And then she eventually proved that she probably could. So she, in fact, lost her funding and got demoted, but she continued to be obsessed with mRNA. She hooked up with this guy, Drew Weissman, and they started to work together. And they were very much marginalized, but they believed that they could use this stuff, put it into a cell, and make that cell produce any kind of protein they wanted. That was the theory behind it. That was the hypothesis. As long as you had the genetic code. And of course, we've got the genetic code for all viruses now, so viruses are a really good candidate. To begin with, they were working on cancer, not on viruses. However, when they injected their mRNA to do this into mice, it was highly toxic. Apparently their fur all ruffled up and they looked miserable and they kind of died, which was, not what you wanted for a vaccine. So they figured out that natural mRNA has a protective molecule wrapped around it, which prevents this effect. And it was these two who discovered what that molecule was, placed it on the mRNA, and then they were able to put that into a cell and make any protein they wished. And here is a picture of the, put my finger here, the ribosomes with the mRNA actually going in and out of them to make proteins. So this was the breakthrough that produced the injectable mRNA, but we're not there yet, because there are another couple of people, Ian McClellan and Barney Graham. They were trying to stabilize the mutations, in fact, on the MERS virus, which is another SARS virus, the one that came from camel. Because the problem is you can make the spike, but it then, the broccoli thing, but it got all wiggly and it wouldn't stay the right shape. And if it doesn't stay the right shape, it doesn't do what you want it to do within the immune system. So they finally figured out the crucial step, which was to synthesize certain molecules in the base of the spike, that stem, that curly stem, that and then they, another team had to produce the change that allowed the injectable material to survive being put in a vial and then put into the body. And so that was the lipid coating. So that is the story. That's where the vaccine came from.
So this shows you simply the daily case and death rates in vaccinated and unvaccinated, with the average daily cases here in unvaccinated and fully vaccinated. And this is current information. Average daily deaths, again, unvaccinated and fully vaccinated. 13 times as high here, 5 times as high here. So I think it just gives the message that vaccines are still the thing that we must have. This simply shows you the level of vaccination. The darker green means more vaccine, and you can see the distribution here just by eye. This shows you the US vaccination by all ages. Fully vaccinated, 63%. 5 and up, that's climbing up pretty well. 65 and up, 88%. But you see for Texas, it's below the US average. So Texas, and you can see here, it's one of the lighter ones. It's not up in the really dark like some of these, even Florida. But Florida, remember, is full of these people, 65 and up. So that helps to explain partly why why Florida is so well vaccinated.
And this is just to show you that what state you live in really matters as to when we will achieve adequate vaccination. And you can see down at the bottom here, we've got Wyoming and Mississippi, North Dakota, and Idaho, but West Virginia is off the map. Idaho is in Indiana. There's Indiana, yeah.
Yeah, sorry, yeah.
Anyway, you want to go on with this?
Yeah, so this is the reported doses being given, reported by manufacturers, and you can see that since June, a lot has gone up. A lot more doses are being given, and that's in part driven by the current big spike in disease. And this just shows you the similar kind of story in New York City, with unvaccinated way up here and the vaccinated way down here. And this is hospitalizations. So you can see a huge difference in that. And you don't know what else to say to people about getting vaccinated, except she got her shot and her vaccine hesitant husband didn't. And he was in a Mississippi ICU bed battling coronaviruses. And they spurned the vaccine. Now they want us to know that they regret it. And we've seen these stories crop up now all throughout. This young woman, 32 years old, unvaccinated, died from COVID before she could hold her newborn child. And another quote from a father, and this is the key thing as well, my 16-month-old son was lucky to get a pediatric ICU bed when he needed one for a non-COVID condition. He shouldn't have needed luck. What does that mean? It means if you're out having and you have an automobile accident somewhere, you may not find a hospital bed if you need one. And that's the other downside of the surge with COVID. This simply shows you what we've already alluded to, that the Moderna, there are a couple of studies showing that Moderna vaccine is marginally better in terms of effectiveness than the Pfizer vaccine. And these studies, these slides will be available to you. You can look at them And see, and this is another one, this is breakthrough infections from fully vaccinated cohorts. And you can see here there are fewer breakthroughs with Moderna compared to Pfizer in this particular study.
And there's a reason for that.
Yeah, the reason is in part because, again, the Moderna vaccine has a higher dose of RNA, and and the way that it is given, it probably has a better boost at 4 weeks, which is the interval between the first and second, compared to the 3 weeks with Pfizer. So this again shows you a greater risk of disease, hospitalization, death among the vaccinated and unvaccinated. This is overall disease incidence in the unvaccinated and the vaccinated. And you can see these are stark differences. This is data from CDC. There are
it's in death as well.
Yeah, and death is 25-fold reduction in death. I mean, if that doesn't give anybody pause, I'm not sure what should. You want to do this one?
So what about boosters? Well, the data sort of are emerging as we speak, but around last summer, the Israelis decided, who are very well vaccinated, we're getting a lot of cases with the Delta breakthrough, and they decided to go for boosters. And then by the fall, it became clear that we needed to have a booster. And the data really showing that the protection declines within about 4 to 6 months, probably 4 months. And the differences in memory cell responses have not been assessed, but neutralization has. And it does look as though really the booster is needed. But the complete evasion has not been yet demonstrated, and that's what we're afraid of. So the overall conclusion is that vaccination reduces hospitalization, disease progression, and likelihood of death. And so if you're smart, you get the vaccine. So this, there is another question here. Can we possibly make a universal vaccine for all COVID variants? Maybe we need to know which regions of the spike proteins are more highly conserved and target them. And then look at the receptor binding domain, which actually flips as well as just sitting out there. But this is very difficult to assess, and it will take us time to do this. I think we just have to wait and see what's happening here. So we're not going to.
So let me say a word about treatment, because there have been some, and this slide will be available to you. You can see there's only one actual FDA approval for treatment for COVID virus. These are widely used ones. Some are EUA approved, and I've marked those for EUA approved. Some are actual antivirals, and others are the monoclonal antibodies that you already know about. And I'll show you what the difference is there, because they have to be given at different times and in different ways. And then there are the drugs that you've already heard about, ivermectin, oleandrin, and all these others that are not promising or plain fraudulent. Of course, bleach, silver, that should be silver, not sliver, and UV light are all absolute fraudulent. There's no evidence. These have been tested, and none of the tests show any promising. All right, so what's the mechanism of antiviral drugs? The difference between the monoclonal antibodies is the monoclonal antibodies act like the antibodies from vaccine. So they attack the virus before it gets into the cell and keeps it from going into the cell. So that's why you have to give that early in order to dampen down the ability of virus to replicate. The antivirals actually attack the replication mechanism. I'm not going to go into all this detail, but you can look at the slides and see what the different antivirals do. And most of these are what are called nucleoside analogs, these antivirals. And what they do is actually they take advantage of the virus's mutation. They actually make the virus mutate even more. But when they make it mutate, because they are substituting themselves in for the usual, the virus is never going to be, all those mutations are fatal. So it causes essentially the virus to mutate itself out of existence. And that's the way most of these work, although there's another one that has a different, slightly different. The one that's actually fully approved by the FDA has a slightly different mechanism. And it combined in a number of different places on the virus as it replicates. So again, and then there are the anti-inflammatory treatments. And so the antiviral and the monoclonals need to be given within the first 5 days or so of illness, whereas the anti-inflammatories are given later. Why is that? Because once the virus takes hold after 5 or 6 days, giving antivirals at that point doesn't really help any, because you've already done the damage and you get this cytokine storm that you've heard about. Well, these anti-inflammatories actually go in and attack that point of the cytokine storm and dampen it down. So that's why you give the dexamethasone, which has its own impact here. This cartoon shows it, and other anti-inflammatories that you can see I've got marked here that have different places where they attack the cytokine storm. So that's the story of essentially of the, this just shows you a little more carefully how the anti-inflammatory parts work and what this cytokine storm is all about. And it's just a cartoon of various pieces of this process and shows you where these anti-inflammatories actually attack the cytokine storm process. But again, they are given later when you start to get the cytokine storm. You don't want to cut off the cytokines initially, because that's what helps to induce the antibody response. So you can see it's a balance. It's a delicate balance here.
So now we'll just finish off the masks, because Omicron is so transmissible. The used cloth masks that we have been recommending really worked quite well, now really aren't working too well. So these new masks, the KN95, are readily available. You can get them in any kind of stores such as Costco or your local pharmacy, drugstore, wherever you can find these. So I would recommend that everybody wears these, and you wear them whenever you're going into company that you don't know, or into areas which are poorly ventilated or crowded, or all of the above. So why should you get a vaccine? Let's quickly say to avoid getting sick, to avoid being hospitalized. You've figured all this out. To avoid dying. Just if you're pregnant, to protect the mother more from severe, probably fatal disease. But don't forget that you also reason for getting a vaccine, and to spare the overworked and stressed nurses and medical staff the burden of your care. They are at breaking point, and many of them are leaving, and getting care for regular illnesses such as a heart attack is becoming questionable. Limit your ability to spread deadly infection to vulnerable people. Protect your community, protect your family, protect the workplace. Help control and limit this deadly pandemic. So it is a community, it is a responsibility, a community responsibility, in fact, to get vaccinated. So what it doesn't do is no chip. You've got a cell phone. Why would anyone want to put a chip in you? It can't magnetize you because you're not made of metal. It has no effect on fertility. No, it does not cause enhancement. It cannot possibly cause COVID disease because it lacks all the mechanisms, the part of the virus that actually does the damage. And it really depends on human behavior and does not induce other diseases. So the arguments are pretty straightforward.
So what do we have to do to learn to live with coronaviruses? First of all, probably yes, we do have to learn to live with coronaviruses. What does it mean? It means we all need to be vaccinated. Whatever else people want to say, vaccines are working. They are preventing severe illness and death, and they're also preventing infection in most people. Boosters may become routine, and that's something we may have to live with. These mRNA or protein vaccines with modified structures probably will have to be created. Masks need to be universal, and one of the things that we've seen, by the way, is we see far less influenza. This year we're seeing a really low level of influenza.
And last year,
and that's probably because people are wearing masks. So we have to do constant monitoring for new variants, and with flexible, rapid responses, particularly looking for variants that might escape vaccine. And the last thing is, this is a global condition. We need low-cost, stable vaccines for the entire world, because until we get, as you can see, one variant came from India, one variant came from Southern Africa. So to prevent this, we have to get people vaccinated across the world. This is the current shape of vaccination. You can see, once again, the darker areas are the higher levels of vaccine, the really dark 80% and above. But you can see there are areas where we have even we don't even have 20% of vaccine. So until we can address this, and until we can get a handle on getting everyone vaccinated, we're certainly going to have to live with COVID in the short term.
Yeah, and the last message is, getting COVID does not make you immune to COVID. These viruses are able to reinfect.
So thank you very much. We'll
you.
be happy to answer questions.
Great. Thank you again for a great talk. I really appreciate it. And so I guess you guys can see the questions too, but I have it at my fingertips. So let me just ask a few of them. And so going to the beginning, first question from Kathleen Pasek. A child under the age of 5 tested positive on January 14th and then positive again on January 21st. From which date do we begin counting her isolation time of 10 days?
The latest.
Yeah, the latest one, right?
Yeah.
Look, this is not hard and fast. I think the new isolation guidelines were kind of rule of thumb rather than driven by science. And they were based also on economic pressures because of the, lack of the workforce implications. So we really do not know, cannot give you a hard and fast answer.
Yeah, and with children, it's even more complicated.
Yeah. We're just hoping the under 5 vaccine will come soon.
Yes, I do hope so. There's another question about vaccines a little further down, and that is taking multiple boosters. Does that have any unintended negative consequences in relation to our immunity? Or as long as these variants are out there and keep replicating and we're not replicating, but spreading, is it a good idea to get multiple boosters when the time comes?
Keep on hitting it.
I think it doesn't have any negative thus far, and we've not seen anything that's negative. And what we've seen is the reason that what's driving the boosters is the fact that antibodies are waning. And so the booster is there to try to keep the memory from being lost. We don't want the memory to become senile and lose its capacity to continue to make antibody. And so stimulating it with a booster is the way to do that.
And I think the other thing that worries me is that we have 4 natural human coronaviruses. They've been around for eons. And the immunity to these for these 4 coronaviruses, they're nothing to do with COVID, but they are coronaviruses and they're in the same family. The immunity wanes and disappears in about 8 months. So the same virus can hit you every single year.
Well, related to that is Omicron now is more virulent, but does it influence how long the time in between getting booster shots in any way? Or can you talked about that just a second ago, but just remind us again.
I think it really doesn't. We're going to have to just set a time but you know what, one of the caveats, if you are immunosuppressed, for example, you may need more frequent boosters. If you have underlying conditions such as diabetes that cause that diabetes itself suppresses the immune system, you may need to get more frequent. And we haven't learned that yet, but it's something that's on the radar screen.
And what we're waiting for is retooled mRNA viruses. They're in the works, they're in clinical trials that are more tailored towards Omicron mutations than the original vaccine. And I think those are the next boosters to get.
Okay. Another couple questions have to do with people who are vaccinated versus unvaccinated and the possibility of new variants coming out. Does it vary at all by individual, would you say? Whether vaccinated or not, do they have a higher or lower propensity to contribute to new variants emerging?
Well, of course, because unvaccinated people are making a heck of a lot more virus than, and this is a statistical game. So
Yeah.
the more virus that's being made, the more likely a variant is to emerge. And if you put all those unvaccinated tens and hundreds of millions of people out there who are unvaccinated, whether it's they refuse vaccine or whether they don't have access to it, you still have a huge number of people making a lot of virus, and that's where the variants are likely to emerge.
Yeah. Let's see. What are the chances the COVID virus was man-made in the Wuhan lab? People have been saying that for a long time, but I think there's new thought thinking on that. Can you share it with us?
Yes, there is quite a lot of circumstantial evidence that does point in that direction, but the actual evidence that we really need was destroyed by the Chinese. Now, you may consider that a red flag, or we may just consider that unfortunate, but it would have been possible. It would have been possible also to spread naturally from bats, but the evidence for that, in fact, is much weaker. So I don't think we know. If it was a lab escape, it would be an accident. And there have been accidents, lab escapes throughout the history of working with viruses, particularly in Russia. There was with anthrax in Sverdlovsk, where a lot of people were infected. And there was a big cover. There was a big outbreak of foot and mouth disease in England, which was not covered up, and that meant that nobody could travel around England for months and months and months. And then there was the smallpox escape in London. There have been smallpox escapes from labs. Once again, that was accidental and went through the air conditioning. So accidental escape is very possible. And there is quite a lot of evidence that this is something that could happen.
Okay, great. Another question, we're starting to run out of time, maybe a tad over time, but when I try to convince people to get the vaccine, they tell me they don't trust the data on the death rates. Where can we get good data on the death rates?
We've got it.
Or is that the answer to that question?
The state health departments are producing it. Texas is producing it.
WHO
is producing it. The CDC is producing it. I think in this case, if people don't trust it, I don't know what to tell them. I have no idea. But these are all, unless they think that all of us scientists are in a big cabal to fool the public and lie, which seems highly unlikely.
Well, why would we do it?
Well, and why would we do it in the first place? Then they need to look at the data that we just showed that are being made by literally thousands of people. You'd have to have all these people conspiring together to think that somehow they were trying to cover something up. So I don't know. I don't know what else to say.
Yeah, well, I appreciate that sentiment, but you know, when someone dies, there's a death certificate that fills out, and is there a place for it to say COVID, or is it a separate reporting system? This is just me asking. I don't know the answer.
I think that they have to be reported to at least the state health department certainly requires reporting of all cases.
Right. But we know in our own community here in South Texas, there were people who died at home with clear COVID symptoms who were never tested. And so they had to be reported as deaths based on clinical, not on laboratory. And that's, we've already mentioned, that's multiplied throughout the world.
And death certificate data is messy.
Yes, it is. That's one of the reasons I asked the question. All right, we're gonna have one more question. If someone has 2 doses of vaccine and recently had COVID, should they wait before getting a booster if they're in the time window, or should they just go and get it?
Go and get it.
I would go and get it. There's no harm in it. And what our experience in measuring this is you will have super levels of antibody.
You're good. If that's your category, you're good.
Yeah.
Well, that's what I'm gonna do. Well, I have done, yes. So thank you again for coming and sharing with us your information and helping people understand this epidemic better. I'd like to say we're not going to have you back, but I'm pretty sure we're going to have you back when the next thing comes around the corner.
Are we're going to put this on HBO or something. I mean,
Yes.
which case we need a props department, I think.
Right.
I'll see what I can do for that. Anyway, thank you again, and thank you, audience, for tuning in. Feel free to share the web link to this to your friends and colleagues if you feel that they would like to see this. We'll have it up online. I know it takes a little time to get it online. I'm going to say probably by tomorrow it'll be up there, certainly by the end of the week. And so anyway, goodbye and good luck, everybody. Take care.
Thank you.
We should stay on for a minute.